the right treatment for the right cancer at the right time. How does it work? Now we have many options for the low-risk, low-volume prostate cancer treatment. The first one is the active surveillance, which can be a little bit stressful for the patient who need to perform a PSA test every 3 months and prostate biopsy every year. The other option that we know today is the radical treatment with the side effects that you know. So in between, we have another option, which is the focal therapy. What is the concept or the principle of the focal therapy is to destroy the index lesion. The index lesion is probably the lesion which will be the most aggressive, and by destroying this lesion, just this lesion, we can expect to keep the quality of life for patients. How to perform, or in which patient, which are the indications for focal therapy. A meeting held in Amsterdam in 2010 in order to define the good indication for focal therapy. The ideal patient is a patient with an unilateral low-volume, low-risk prostate cancer without any history of prostate cancer, a clinical stage T1, CO, T2A, a PSA less than 10, diagnosis of course proven by a biopsy, a lesion score less or equal to 6, less than 30% of positive cause, and less than 50% of tumor involvement on each course. The MRI is recommended, and we don't have. We must respect MRI stage less than T2B. And the patient must have a life expectancy more than 10 years. Of course, they must be well informed that we will treat just a part of prostate, and there is a risk of recurrence at this side, but also in the other part of the prostate. So how to be sure that we will treat the good area, the good zone? We don't know. We know that we probably have to repeat the biopsy, but how to perform the biopsy, we don't know. We don't have any answer. It's just suggested to do a transperineal template biopsy in order to have a good mapping, a better mapping of the prostate, and in order to have a better approach of the prostate cancer. Another option is the MRI ultrasound fusion guided prostate biopsy, which can be easier to perform, especially at the clinic, avoiding the general anesthesia and the hospitalization which is mandatory for the template biopsy, at least in France. We know where the tumor is located, so now we have to choose a treatment, a focal treatment. Many options are possible. The target therapy, which in which we treat just the lesion and only the lesion, the hemi ablation or the subtotal treatment. In our department, we decided to do an hemi ablation due to the fact that we don't know exactly where the tumor is located, because of the detection, as I told you, can be very difficult in some times. How to follow the patient? We have some rules in our department, and we suggested to do a PSA level every 3 months for 1 year, and then every 6 months, and MRI, evaluation of functional results, and of course the control biopsy, which is necessary at 6 months or between 6 months and 1 year, or in case of failure treatment suspected. How define the treatment failure? The treatment failure must be defined as any positive biopsy in the treated area, and probably in case of biochemical recurrence. We don't know which definition is the better one, because you know that we spare a part of prostate, and so the patient will have a higher PSA, of course, than after radical treatment. And the definition that we have today for the biochemical failure are the definition which have been defined for the world-run treatment after irradiation, as Astro definition, Phoenix definition, or others. So we know where the, we probably know where the lesion is located. We know how to treat the patient, AMI ablation. So which energy are available today? Four energy are available: the HIFU, the cryotherapy, the photodynamic therapy, laser, and the brachytherapy. All of them have some advantages and some limitations, but the most important with this treatment are that we can retreat the patient without any inconvenience. So the patient must know that if there is a failure, we can retreat them. So let me show you the different energy. The first one is the high intensity focused ultrasound, which is a typical transrectal approach with ultrasound guidance. The mechanism is vibration at the target zone, which will increase the temperature of the tissue and create an hyperthermia with a coagulative necrosis. There are few limitations of this treatment. The size of prostate. Patient must have a prostate less than 50 grams, and the location of the biopsy. We don't recommend to treat in focal treatment the apical lesion. You can see on this slide the position of the patient, which is under general or spinal anesthesia. We introduce the probe into the rectum, and we have real-time ultrasound control. We define the target zone, and on the three other slides you can see the, you don't have a pointer? You can see the MRI before treatment on the left one. Then just after treatment, 1 week after treatment, you can see the hypo intensity. Thank you. So here is the MRI before treatment with the lesion which was located there. After treatment, 1 week after, and 3 months later. So, and the biopsy, which were positive at this part, were negative at the control biopsy. So we started our experience 10 years ago, and we published a short series of focal therapy after 10 years following. And in our opinion, the results are pretty good, because we had 58% of patients of survival recurrence free. In patients where the cancer was the selection was very different than the selection that we do now, with a really low disease for focal therapy. Before 10 years ago, we did only 6 biopsies. We included patients with lesion 7 and PSA higher than 10. Recently, you probably read this paper from Mark Humberton team. They published a series of 42 patients who had a focal treatment with different criteria of inclusion. The PSA was less than 15, and the Gleason score at 7 were accepted. They reported a very low morbidity rate with 22% of dysuria, and a good oncological results, because 77% of the patients were cured, and the control biopsy were negative at the point of the treatment. So the conclusion was that focal therapy of individual prostate cancer lesions, whether multifocal or unifocal, because they also treated multifocal lesions, but they treated all of the lesions, lead to a low rate of genitourinary side effects and an encouraging rate of early absence of clinical significant prostate cancer. Which is very encouraging for the future. The other option is the cryotherapy. How works the cryotherapy? It's based on the Joule-Thomson effect. So we use high pressure argon gas, which flows through a cryoprobe, and it generates at the tip of the probe a very cold temperature. There is at minus, when the temperature drops to minus 7 degrees, in the tissue there is an ice formation around the cells. When the temperature continues to drop at minus 15, we have an ice formation inside the cells, which will cause the death of the cells. And at the end, we have the formation of tissue necrosis. The quality of the necrosis will depend on the temperature that we can deliver to the tissue, and the duration of the freezing cycle that we have to respect. We have to respect 2 cycles, 1 freezing of 10 minutes, 1 thawing of 10 minutes, and then we have to repeat these 2 cycles. This is one example of treatment. So we introduce, this is a transperineal approach. We introduce the needle inside the prostate. We can do a pre-planning treatment using the MRI, and then we place the needle under ultrasound control. This is the ultrasound during this procedure, and you see perfectly the needle.